2 years ago, I had a broken ankle. My left ankle was broken, and the doctor operated on that ankle. And the hospital visit and stay was all right, except for one thing, and that is that they did not give me enough painkillers after the operation. So I went for 2 or even 3 hours of lots of pain. My sister was with me at the time, and she did go out and talk to the nurse and tell her that I needed painkiller, but the nurse said that she had to call the doctor first to get his approval, and it took her a while to get the doctor. The next time, if I ever have to go into an operation again, I'm going to have a discussion with my doctor about the pain, and maybe he will coordinate with the nurse so that my painkiller will be given to me at the appropriate time, and I won't have to endure all the pain that I did this last time.
Well, yes, I went to the hospital about 6 months ago, and of course, you know, it's frightening, especially in emergency. Well, I think you have to turn around and say, I'm going to the hospital. It's not the end of all things. You have to be calm about it. Before you go, or every day, just have a list of the things that you need and want. And it makes a whole difference, because then you don't worry.
Hello, I'm Ann Hall. Welcome to Mature Living, a program that features topics of interest for older adults. With today's changes in the healthcare system, it can be quite daunting to enter a hospital. Much has changed, but the more you understand these changes, the more you will be able to prepare for a successful hospital stay. There are 2 ways to enter a hospital, either as a planned admission or through the emergency room. Today, we'll focus on a planned hospital admission that you have arranged with your doctor. However, much of what we discuss today will also be relevant in the event that you enter a hospital through the emergency room. Joining me for the first part of today's discussion are Bill Vaughn of the Virginia Insurance Counseling and Advice Program, Marie Woodard, administrator of the home care agency Thrive at Home and a member of the county's Long-Term Care Coordinating Committee, and Christy Clark of Insight Memory Care Center in Fairfax. Bill, we'll start with you. You've been tracking changes in the healthcare system for your entire career. And in fact, I understand that you began as a staff member for a congressman who played a key role in passing Medicare back in 1965. So from your perspective, how have hospitals, and in particular the hospital experience, changed over the years?
Oh, in so many ways. We're living 10 years longer than we did back then, and so hospitals are treating much frailer people. But in about half the time. Back then you stayed in an average of 9 days, now 5 days. And a big one, I'm afraid, is costs are way up. You gotta have insurance. If you're uninsured today, the average charge that you'd be billed is about $8,000 for a day in a hospital. And Medicare people, they need help with Medigap policies because the first day deductible that you owe in a hospital is $1,288.
So are there other things that have driven the change besides cost?
Oh, well, this is, I think, largely driven by high technology. I mean, think of laser surgery. You can do something on an outpatient basis that used to be a whole week in the hospital. But there's very few high-tech devices that seem to be cheap. They're expensive. Right. And that causes the people who are paying the bills to say, hey, can we get you out of the hospital faster and save some money? Also, can we fight fraud? There's some fraud in the healthcare system. And we urge everybody, if you see something on your bill that has nothing to do with reality, report it. You can get a reward, you can help hold down premiums, you can help hold down taxes, but help us fight fraud.
It seems like hospitals are emphasizing the quality of care more than in the past.
Well, they should. In 2001, there was this famous Institute of Medicine study that showed about 100,000 unnecessary deaths by error in the healthcare system. That's just staggering. Imagine another industry like that. If you brought this home to our area, our share of 100,000 deaths would be about 2,000. Imagine if Metro had an accident every day of the year that killed 5 or 6 people. We wouldn't be trying, we wouldn't ride on Metro. That's why you shouldn't casually go into a hospital and why they should be working on quality. And in the Affordable Care Act, Obamacare, we quit paying hospitals for never events. Never event is something that should never, 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 ever happen. Like you go in to have your left leg cut off and they cut off your right. Don't pay for that anymore. We don't pay for poor quality.
So what advice would you give an older person who is facing a planned hospitalization?
Well, Medicare.gov has a neat guide to picking a hospital, to picking a hospital, and it's a long checklist. I would go on Medicare.gov, find a hospital, and Medicare now rates hospitals with a star system for what your neighbor's experience has been, how well they let you sleep at night, how well they answered your questions, that kind of thing. And more seriously, if you're doing hip or knee replacement, there's a hospital in Fairfax County that has better than national average quality and one that has worse. For gosh sakes, avoid the worst one. So go to those websites and look at those quality indicators.
Very good. Another insurance issue that some people are confused about is the observation care status versus the admission status. Can you talk about that distinction and why we should?
Sure. This is, you need to know your benefits under your insurance plan, under your Medicare plan. Say 2 people enter the ER, and one, I had a heart attack a month ago, and I feel like you'd go in and you'd be admitted, and you'd start earning, after 3 days, you would earn a Medicare benefit of 100 days in a skilled nursing facility for rehab and recovery. The other person goes in and says, I think I'm having a heart attack, but I had a Sichuan burrito for lunch. The doctor might say, maybe that's heartburn, Bill, and we're going to observe you. You don't start earning the 100 days, and you pay differently.
Thank you so much, Bill. Marie, you represent the county's long-term care coordinating committee, and that group recommends that people plan for hospitalization by maintaining a personal health care record. Can you tell us about that?
Yeah, our committee developed a personal health care record with the goal of organizing all your health care information in one place. So in this personal health care record is going to be your emergency contacts, the name of every physician you have, not only your primary but your specialty physicians, your diagnoses, your recent hospitalizations, your surgeries, all of your medications, when you started them, when they were discontinued, when the dosage changed. So this is an ongoing process of keeping this record updated with what's going on. Another thing, immunizations. Do you really know? Did you have your pneumonia? Did you have your shingles shot? Did you have your flu shot? So that in one place, you have all of your information. In there is also a discharge checklist of what you need to know before you're discharged from the hospital.
Now, some medical practices offer online medical records to maintain this kind of information. If you have if you're with a doctor, it has this sort of online thing. Should you still keep a personal health care record?
Yes, you should, because you will go to doctors that do not have access to the electronic health record of your doctor. One question to ask your doctor, who has access to this? You have access to my record? Does the hospital have access? Does the urgent care have access? Does the surgical care center I'm going to? So you're going to have a lot of care outside of that electronic health record. So you should always maintain your own health record. Make sure that you have it accessible to your advocate. Take it to the hospital with you, and then in the event that you are on vacation and you go to a hospital completely out of your area, you should have that with you too.
So if I wanted to create a personal health care record, is there a template available somewhere that
Yes, on the website, you can go to the website. There is a template that you can download your own personal health care record, but then there's also a format where you, as an organization, a church group, a community group or something, can download one and put their own logo on it.
Bill and Marie have given us good advice on how to prepare for our own hospitalization. But what if you were a caregiver for someone with Alzheimer's disease or another dementia? What do you need to consider when your loved one must be hospitalized? Christy Clark is here to advise us. Christy is the Outreach and Education Coordinator for Insight Memory Care Center, a program that offers services to adults with Alzheimer's disease and their families. Christy, first tell us how dementia could affect how a person experiences a hospital stay.
For somebody that has dementia, when they enter a hospital, they're going to be more disoriented and more confused. A person with dementia does best in an environment that's familiar to them, with a structure and a routine. And going into a hospital for the person with dementia just throws this routine off, and they do become more confused and disoriented.
So I understand that caregivers of loved ones, you recommend that they go and stay with the patient through the entire hospital stay, is that right?
That's correct.
And is this person to act as a patient advocate as well?
Right. You know, and I think when you have somebody with dementia, not only are you their caregiver, but you need to act as their advocate as well. You know, for somebody with dementia, it's not necessarily a question of if they're going to enter a hospital, but it's really when. And so in terms of being an advocate for them, it's making sure that you can communicate their needs. You can communicate with the hospital what was their baseline before they entered the hospital, so we can see if maybe there's some delirium because of pain or a surgery that they had to have. And also being that advocate of making sure that their wishes are carried out, having their advanced medical directives and being able to communicate that with the hospital staff.
Right.
And you also want to make sure as an advocate for somebody with dementia that you are talking with the nurses and the staff at the hospital, ensuring that they're comfortable and bringing along things that are comforting to them, if it's a favorite blanket or if it's music that may calm them down. Just communicating with the staff the best way to communicate with that person with dementia, and what some of their behaviors might mean.
This is a lot.
Yes.
And I'm exhausted listening to this. So can you recommend a way for a caregiver to plan ahead for hospitalization?
I think for most people with dementia, the hospitalizations usually are not planned, just because it is so difficult, especially the disorientation after somebody goes to the hospital to have surgery. Going under anesthesia, a lot of times the confusion is worse. So I always, recommend to families that they are prepared, that they look at who they have in their circle of friends or families. And I always recommend that 2 people go to the hospital, because you want to make sure that if you're doing the admissions paperwork, or if you need a break, because it is going to be very stressful, that somebody is there as that advocate for the person with dementia in your absence. And also planning, packing a bag ahead of time, making sure that you have all of your legal documents, your list of medications, those comfort items, as well as packing a bag for yourself, because you're going to need your own medications and your own comfort measures. And one of the nice things is a lot of this information can be found in a book that the National Institute on Aging puts out. It's called Hospitalization Happens. It's how do you sort of get through a hospital stay with somebody with dementia, and they have a lot of great information in that book of how you can plan for those hospitalizations.
Hospital Happens.
Right.
That's good. Well, thank you so much, Bill, Marie, and Christy. Thank you so much for joining us today. This is all very useful and helpful information. We'll be back with the second part of our discussion right after this.
I'm a caregiver for my husband, and he has dementia, and he he's been to the hospital twice this year. In both cases, it was probably an emergency situation, and there wasn't a whole lot I could do to prepare, I don't think. And my husband is very easygoing, and he didn't have a real problem with it, so he was not agitated as some people might be, but I don't know what else that I can say as far as he's concerned, because he seemed to know that people were trying to help him. And I didn't realize that once you go into the emergency room that you have to wait hours and hours and hours. I think we went in at 7 o'clock in the morning, and I don't think he got to bed until 4 o'clock in the afternoon. For myself, preparing for a hospital stay, I think that I would make sure that I had a book, or that I had a book on tape, or a crossword puzzle, or a newspaper, or something to bide away the time, because they were working on my husband a lot of times, taking blood pressure, doing this, doing that, and there wasn't a whole lot that I could do except sit there. The one thing I would suggest in preparing for a stay in a hospital, a doctor's office, or whatever, is to bring a list of medications. And I've found that I keep that list on my cell phone now, so I can change it if the doctor changes it, whatever, and I have it with me, and it helps a whole lot. I think maybe everybody that has a person in this situation maybe ought to think about what would happen if they went into the hospital. And one of the things that they're very adamant about is what's going to happen when he gets out, or she gets out. And they want to know if he's going to go into a rehab center or if he's going to go home. The staff does work with you on discharge, and there are physical therapists and there are occupational therapists, and they go over what needs to be done and what sort of situation you need at home for his competencies at that point. My husband uses a walker, and they suggested that you not use it on rugs. So I had to get him in a place where, luckily, I don't have a whole lot of rugs. But the one area that I could have put him in, that I have an apartment on my house, a whole apartment, and but it's totally carpeted. The rest of the house has either hardwood floor or tile, so I had to move him to another place where he wouldn't have a rug.
Welcome back. In the first part of today's show, we learned how to prepare for a hospital admission. Now we'll discuss how to effectively navigate the hospital and post-hospital experience. Here with me to discuss this are two guests from the Inova Health System. Dana Green is the Director of Transitional Services, and Michelle Mullaney is Senior Director of Case Management. Welcome. Michelle, earlier Bill Vaughn discussed the changes in healthcare and how this has impacted hospitals. So from your perspective, inside a major hospital system, how would you describe how the changes have impacted the hospital experience?
I think the most overarching effect is that of focus on safety and culture and quality in the hospital. Inova itself has really taken great strides to ensure that the right care is given at the right place at the right time. And that's the most important consideration for consumers to bear in mind. We focus on things like readmission prevention, making sure that the care we're given is in an appropriate amount of time to allow the patient to transition to the next level of care. And we really try to focus on infection prevention and the overall quality of the hospital experience.
Mm-hmm. Bill also mentioned the observation and admission status in a hospital. How is that determined?
There are three statuses a patient can be entered into once they come into the hospital.
Mm-hmm.
They are inpatient, observation, and ambulatory. These statuses are set forth by Medicare and based on evidence. Clinical criteria are established, and a utilization review nurse looks at a patient's chart and their symptoms, places them into a category, and reviews them daily for continued accuracy. Mm-hmm. A physician advisor, independent of that nurse, also reviews charts to ensure that the patient is in the correct status.
So we all know that hospitals are busy places with multiple around-the-clock providers, with nurses and doctors and therapists and aides. And so how do you keep all of these people on the same page?
That's a great question. First, Inova has done a great job in investing in technology. We have an expansive electronic medical record, which not only focuses on inpatient treatment, but extends to our outpatient and transitional clinics as well. So all providers within the Inova system, from primary care to inpatient hospitalization, have access to that record. Additionally, we've embraced mobile technology such as Tiger Text for immediate responses and communication between doctors, nurses, and case managers. And that's really enhanced our ability to communicate in real time. We also do daily and hourly rounding, both interdisciplinary with the entire care team, as well as at the bedside with the patient as a participant in the rounding.
What advice would you give to someone who is planning for a hospital stay?
If a patient is lucky enough to plan for a hospital stay, I would really encourage the patient and family to feel empowered to ask questions of the care team, ask for clarification on the diagnosis, and ask to reach out and speak to any member of the care team if they have any questions. I would also encourage them to speak with their family and loved ones about advance directive and care planning so that the team in the hospital is aware of what the patient would want. I can't stress how important it is that family and caregivers feel like they have the best interest of their loved one when they go into the hospital.
And that really frees the loved ones as well.
It does.
It makes it a little easier for them.
Yes, it does. They know that they're doing what their family member would want.
Mm-hmm. So tell us about the role of the discharge planner. Who receives the discharge plan and what does that entail?
A discharge planner is a part of the case management department. They are often social workers and can be registered nurses as well. The discharge planner starts from the day of admission on anticipating what the patient may need as they move through the continuum of hospitalization through the day of discharge. A patient's care while in the acute care setting can change rapidly, sometimes in a matter of minutes or hours. And the discharge planner's job is to diligently stay on top of that care plan and communicate changes to the family as well as back to the physician and nurses as well. A discharge planner also will set up referrals, work with families on where they may see their loved one going based on the new normal after this health incident.
Very good. So what are some of the things that hospitals are doing to help caregivers and older adults, and especially people with dementia, navigate the hospital stay?
At Inova, we have a geriatrics team, and we have interdisciplinary teams that are talking about each patient's care plan. We really want to focus on individualizing diagnoses such as dementia and Alzheimer's, as we acknowledge that each patient's presentation with these symptoms can be vastly different from one another. Mm-hmm. It's important for caregivers to communicate the special needs of their loved one to the care team and how they may be affected by the hospitalization. Hospitalization can be in itself a very stressful experience. To add on a memory loss or dementia diagnosis can be extremely stressful and downright scary for a patient and family. So really communicating those needs to the care team and asking for assistance and asking what resources are available is really important.
So it is important to the dementia person to have a patient advocate working on his or her behalf.
Certainly, absolutely.
Yeah, very good. So Dana, transition services. Could you tell us a little bit more about what this is? Is it something new, and how does it work?
So transition services is really a relatively new concept in healthcare, but it's really about the paradigm shift of thinking that the hospital is no longer the place to not only get stabilized, but to get to heal. And so transition services is about helping patients learn that the continuum of care doesn't just stop once they leave the hospital, that there's an entire care team and resource in the outpatient world to help them transition from hospitalization to home. So Inova's response to this growing need of helping patients transition out of the hospital was to develop the Transitional Services Department. And so transitional care management and our discharge clinics are a part of that department. Transitional care management helps vulnerable patients with chronic diseases who are at very high risk for readmission or for an incident happening soon after a hospitalization. So there's an entire case management team that are there to help patients do everything from walk them through their medication management program, ensure that there were no issues post-hospitalization, make sure that they have a follow-up appointment and know how to talk to their doctor about their hospitalization, that they understand what their disease process is and how to educate them about the symptoms so that they can be proactive in that response instead of having to call 911 when it gets so bad. We also help patients understand, much to what Michelle said about advanced directives, how to be preventative and proactive in their care, in their health and wellness. We do depression screening, as chronic diseases often can be very difficult on your mental well-being, as well as just a whole plethora of psychosocial resources and coordination. The discharge clinic component of our services helps patients who either don't have a primary care physician or don't have access to their primary care physician in a very quick turnaround from their hospitalization stay. So we're really a short-term service to make sure that those patients don't fall through the cracks, that they get immediately seen by a team of physicians and nurse practitioners, case managers as well, to ensure that they, after hospitalization, that everything is still going well, that they have a place to be seen, stabilized, ensure that everything transitioned well to home, and then we get them to a medical home in the community or back to their PCP to ensure that there's a transition there that happens for them. So it's really to make sure that those patients, all of those patients that are vulnerable, get services after a hospitalization, that they're tucked in, that they have the resources that they need and the care that they need to be well.
That's wonderful. And the follow-up, too, without having to worry if you can schedule an appointment. That time, that takes away that timing issue.
Correct.
So what can people do to be active participants in their own health care, both inside and outside of the hospital? What can we do?
So absolutely, I would want to empower patients to understand that they are the most important part of their health care, that the rest of us are here to ensure that we have the resources available and that we help them to get connected to the services that they need. So some of what that means is meaning that they go in with the expectation that they are going to have a care coordination team, both inpatient and outpatient, and to really be an active participant in that care team, to engage in those phone calls when case managers call, to follow up with their physician in a timely manner, to ensure that they know about their symptoms and how to manage them appropriately, and that they have a whole service and a whole team, a care coordination team that is really about making sure that they have everything that they need. It is about also, I would encourage all patients to really understand that they have the ability to make some preventative actions. I think a previous panel talked about the personal health care record. We talked to our patients about that as well. Knowing who their doctors are, what medications they're supposed to be taking, when they've been hospitalized before, creating a really good solid history so that every part of that care team really understands fully how we can best intervene at the best time and in the right way. And making sure that they take advantage of doing advanced directives so that, God forbid an emergency does happen, that their wishes are really granted in the way that we would want them to be, not, that the right people are speaking for them, and that as much as a preventative measure could take place in knowing what they would want in advance is being done.
And it removes a big burden to the family as well.
Absolutely it does.
Right, great. Dana and Michelle, thank you so much for joining us today, and thank you for offering such important insight into how to get the most out of your hospital stay.
Thank you.
And thank you, our viewing audience, for watching this edition of Mature Living. I'm Ann Hall. We'll see you next time.